I'm busy taking notes over here as John's speaking. So to begin with, we're going to start out today once again giving you some of the data we have and also answering, just as the Lieutenant Governor was saying, some of the questions that were raised yesterday. So we'll go ahead and start. Today we do have confirmed cases total, 7,791. We have cases in 87 of our 88 counties now. We've documented cases and community spread. And deaths in Ohio have now totaled, as of reporting today, 361 deaths. Again, it's really important to say that we still know that these numbers are the tip of the iceberg for very many reasons, mostly because of our lack of testing and some issues with reporting, which we'll be digging into deeper in the days to come. But I'd like to then go, what do we have next here? Here is our usual. We have now 71,000 tests having been run in Ohio, and everything else is pretty much sticking the same. We're still seeing hospitalizations because we're targeting our testing to highest risk groups at 29% of cases, ICU missions being 9%, healthcare workers making up 21% of our cases, and of that, long-term care residents at this point totaling 700 of our cases. So let me go back to some basics about our data. Do we have any others? Let me just make sure I haven't missed something. Oh, very important, and maybe I'll leave it at this slide. Very important for us is following trends, and I'll tell you why here. First of all, we made a commitment a long time ago, especially in an area of just great disruption and unprecedented change, to share with you what we know when we know it. And I think that's really important for so many reasons, but most importantly, it is about trust. And it is about a time where it's really hard to understand all of what is happening to us. But these are complicated things we're sharing. So let me start first with data. So we're sharing with you a lot, and on our website, there's much, much more than I'm sharing here, epidemiologic data. Now, this is data we collect with every infectious disease. It's a routine part of trying to really understand the spread of disease. But we are in something that has numbers and changes that are larger than anything we've experienced before. So some numbers that we give you are what we know now, and some of them are more helpful to look at in more nuanced ways. So for instance, we give you symptom onset data. That's epidemiologic data. We hear about a case on a given day, but our epidemiologists go back and they look at when did symptoms actually start, because that's much more important to us clinically in detecting this. So symptom onset data is different than some of the other data we report, which is the day we get those cases defined or test results. Another thing that is different is the day a person died versus the day we learn about it. Death data, and we'll go into this in much more detail, this is something that's being discussed, has always been a difficult thing. By the time someone dies and they actually get diagnosed versus the time it takes to get to vital statistics and then is reported in mass unaggregated, those are always complicated issues, and I'd really love to delve into that at some point. But one thing about the data we're showing you in some of our graphs is that yesterday, for instance, we had been reported that we learned that there were 50 Ohioans who died yesterday. Some of those Ohioans who died the day before. Some of them died possibly a couple weeks ago. There are people that died today. We learned today of 37 deaths in Ohio. There are actually people who died today that we will not learn about for days to come. So that data is coming in for various reasons. Sometimes someone dies and their actual test result has not yet returned. that has diagnosed them as being a COVID death. So that data is different than saying how many people we learned about today. And you'll see that, and when you go back and when enough time has passed, that's how we do our sort of annual reports of death and things. But that data is constantly moving as we're learning. And very difficult in this pandemic is the fact that it is a long incubation period in this disease. So we have people who are asymptomatic who have the disease. By the time their symptom onset occurs, which we actually learn about once we know about them as a case, and we don't know about most of our cases that are at home recovering, but of those we know, their day of onset of symptoms is usually about 5 days, but could be as late as 2 weeks. And then it is days and days and days before someone who has this disease might get sick enough to be hospitalized. And then we get hospitalization data. And someone is in the hospital, but they might not yet be in the ICU, and we get those ICU numbers. And then people dying is lagging far behind that. So it goes back to that starlight example I gave you back in the beginning. Some of the data we get is real time, it exactly happened today, and some of it is telling us about things that might have happened weeks ago. But the important thing for all of us is that we compare apples to apples and oranges to oranges and be consistent in that and look at all of that data in the context of trends. And that's so important too. Another thing that can complicate data is reporting. And sometimes, while we would like everything to be, like the Lieutenant Governor said, in a cloud-based system in real time, a lot of our systems are older that exist, that we use. We're all fighting to modernize them, but that's, again, a story for another day. But that this data is important to know that we're capturing it and comparing it over time. And that really gives you what is useful information. So on a weekend, on one given small hospital perhaps, maybe the person who reports that was out sick that day and there wasn't a refill. So oftentimes we even find that weekends can be tricky and that on Mondays we might get a clump of data that was over the weekend. And that's why, again, data is useful, but we always have to look deeper and understand the data, understand what's good and bad about the way it's reported, and look at it over time to give us informed decision making. Our decisions are made on so many things. They're made on data, they're made on better and better data all the time on this disease, but they're based on a lot of other factors as well. But we promise you to give you everything we have as we know it, and that'll be an ongoing dialogue we have.